Welcome to today's webinar entitled When TB is the Least of Their Worries, TB and HIV, co-sponsored by the Southeastern National TB Center and the North Florida AETC. Today's presenter is Dr. Beth Gadkowski. Dr. Gadkowski is currently a clinical associate professor in the Division of Infectious Diseases and Global Medicine at the University of Florida, where she specializes in HIV care. Prior to coming to Florida, she was a TB consultant for the state of Virginia for 9 years. Today's moderator is Dr. Connie Haley. Connie is an infectious diseases physician trained at Vanderbilt University. She has worked in TB since 2001 and currently works as a medical consultant for the SNTC. Now we'll turn it over to our presenter, Dr. Gadkowski.
Thanks so much, Linda. I'm really happy to be here, and thank you for the kind introduction. And we're starting right on time. For those of you who are joining us right now, we started a little bit early, and I'm going to be spending the next hour or so with you all talking about when TB is least of their worries, focusing specifically on HIV. Our objectives for the day, for today. There we go. Oh, first of all, sorry, I have nothing to declare as far as disclosures. And our objectives today are to define the epidemiological link between HIV and tuberculosis to enhance global TB elimination. We're going to recognize common complications for TB case management for patients with HIV to enable improved clinical outcomes of both diseases. And we're going to illustrate how to include HIV testing and referral to care as part of a targeted testing and treatment of latent TB infection to maximize TB prevention. And we're going to start with an audience poll. This is just to get a feel for what everyone's experience is with regards to HIV and HIV care. Have you participated in the care of a person living with HIV, which we shorten to the acronym PLHIV. Sometimes a W is also in there, PLWHIV, and I'll use this acronym throughout the course of the talk.
Connie, I think you're muted. There you go.
Hey there. So I'm sorry about that. Beth, thank you for being here today. We're excited about your presentation, and I've always admired how much you know on the topic. And so it looks like from our poll, in terms of how many people, looks like the majority of participants have worked with patients who are living with HIV infection, about 72%.
Excellent. That's terrific. Okay, so everyone has some experience. I think that a lot of times it depends perhaps where you live or what your role is. And I think it's important because every day you're probably interacting, working with, perhaps living with, related to someone who does have HIV, and it can be a big part of life for people. It's important to be familiar with it. Now, unlike so tuberculosis is a very old disease, and unlike TB, HIV is fairly new, and it's a disease of my lifetime. I'm in my mid-40s, and I can remember being a little girl and reading about HIV on the cover of Time magazine. And I'm using this slide to remind me of where we've been and how far we've come with regards to HIV. This is a picture of Mrs. Jeannie White Ginder, who is the mother of Ryan White, who was a young boy who was diagnosed with HIV when he was 15 years old. Ryan White had hemophilia, and he had contracted the disease through factor that he needed in order to control his hemophilia. After he was diagnosed, he was refused entry to school, and this became worldwide news. And Ryan and his mom then basically became the face, or one of the faces, of HIV and the stigma that was associated with it. And Ryan was amazing because he didn't back down. and neither did his mom. And he wanted to go to school, and they moved so he could go to school. And he actually testified before Congress about what it was like to be living with HIV and the need for drugs to help treat the disease. Ryan died in 1990, and it was around this time, though, that Congress enacted the Ryan White Comprehensive AIDS Resource Emergency Act of 1990, which we know as the Ryan White Act. And this act is what enables many of us who care for patients with HIV to provide care for those individuals when they have no other means such for insurance in order to get care. So Ryan White's legacy is pretty amazing, and his mom continues to speak and is incredibly inspirational. So where are we today with regards to HIV? The summary of the global HIV epidemic in 2018. There are almost 40 million people worldwide living with HIV. And it sounds like a lot, and it is. And the beautiful thing, though, is that those people are living with HIV, and that's a testament to the antiretroviral therapy that we have available to us. Unfortunately, 1.7 million people are newly infected annually, and people still die. Almost 1 million people died from HIV in 2018. And a lot of this is because people may not know they're positive, and they may not have access to medication. And so basically, people are living, but we're still not to the point where we're able to prevent new diagnoses and prevent deaths associated with HIV. Where is the majority of HIV? So of the 40 million people worldwide, you'll see that 20.6 million people live in sub-Saharan Africa. And this will be important as we go through talking about the co-epidemics of TB and HIV. When we look at HIV, and we look at the early 1990s, which is when the peak of the HIV epidemic occurred, we see that people were dying, people were newly infected. But then around 1996, we hit upon a cocktail of medications that included protease inhibitors that was referred to as HAART, highly active antiretroviral therapy. And this changed the game for people with HIV. People started to live longer, and so unfortunately the related deaths sort of lagged after this, and that was partially because the epidemics in the United States and elsewhere hit at different times, and less people were infected. And so we see with the advent of drugs that are able to control the illness, that we have less infection and less deaths. Just a reminder, while we have ways to control HIV and prevent HIV, we don't yet have a cure for this disease. We're working on a cure. It is tough. There have been some people who have been cured, but those cures are not necessarily appropriate for everyone involved. In the United States, at the end of 2016, 1.1 million people were living with HIV, and importantly, about 14% of those people had not yet been diagnosed. Those folks who haven't been diagnosed not only are at risk for progression of HIV, but they're also at risk for passing it on to others. And so it's really important for people to know their status, and that's how we refer to it, know your status. In 2017, we had almost 40,000 new HIV diagnoses in the United States. This number hasn't really changed since about 2012, despite the fact that we know how to prevent and treat HIV. The majority of the diagnoses were amongst African-American men. It disproportionately affected gay and bisexual men. And it also, 52% of these diagnoses were also in the South, and 50% of people living with HIV also live in the South. There tends to be a very disproportionate amount of HIV in the southern states. Take a look at this bar graph on the side, and you'll see that new diagnoses occur in all age groups. Just because someone is older doesn't mean that they necessarily are not at risk for HIV. When you're older and you're sexually active, you may not use condoms because you're not worried about getting pregnant, but you are at risk for STDs, HIV included. What I'd like to point out, though, is that in the 25 to 34 age range, we had over 13,000 new diagnoses. Most of these individuals were not even born at the time when HIV was discovered. And we are missing this population with regards to messages about protecting themselves through safe sexual practices and also using medications such as pre-exposure prophylaxis. So what is HIV? HIV is a retrovirus. That means that it's made out of RNA as opposed to DNA. And its primary job is to infect and destroy CD4 cells. CD4 cells are a type of white blood cell, just one type of white blood cell in the immune system, and it preferentially attacks these cells. A normal CD4 count in a normal individual without HIV is between 460 and 1600 cells. And this this range varies based on what lab you use, but anywhere in there is considered normal. It's such a wide range because there's so many different types of people in the world. I am not HIV positive. I don't know what my CD4 count is, but it could be 400, and I'm a perfectly healthy individual. The other number that we look at is called the HIV viral load, and we abbreviate this VL. And the viral load, when we detect it in someone's blood, can range from anywhere from undetectable if they're on medications, which is less than 20 copies on the lab that I use, and it can detect up to 10 million copies. And so there's a very wide range. And our goal when someone is on medications is so that the virus is so well controlled that we can't see the virus and therefore it's undetectable. If we take a look at the typical course of someone who is HIV infected and is not on treatment, the time from diagnosis to the development of AIDS when they become very sick can be quite long. It's usually about 10 years. There are some people who progress a little more quickly, but for the most part, individuals will be living for 7 or 8 years before they become sick. And if you take a look on the x-axis, it's time, and on the y-axis, it's the number of cells. And this individual starts out with a CD4 count around 900 or so. Once they're infected with HIV, which is the red line, the viral load going up, the CD4 count drops precipitously. And when the person has what's called the acute infection, the viral load is very, very high. The body sort of gets it together and is able to control the virus and bring the viral load down. The CD4 count rebounds, you'll notice not as high as it was previously. And then the person is generally asymptomatic. Some people will present when they have the acute retroviral infection with something like a flu-like illness, and they may be diagnosed at that time, but a lot of people don't experience that, and they remain asymptomatic with their CD4 counts kind of hanging out and their plasma viral load relatively well controlled for a while as their body is able to control it at this point. Remember, we don't have a cure and it can't eradicate it. And so what happens though is that, you know, this person who's infected is going along their daily life, and after a couple years, the body sort of poops out. It just can't do this anymore. The CD4 counts start to drop, the viral load goes up, and the lower the CD4 count gets, the more likely that person it is to become sick with other illnesses, and that's what we call AIDS. So what is AIDS? I don't use the term AIDS. I don't use it with my patients. It is not considered to be a great term. It's not something that anybody wants. And once you start using the term AIDS, patients think that there's no coming back from having AIDS. AIDS is what happens when someone is infected with HIV and they have either a low CD4 count, which is less than 200, or an AIDS-defining illness. And before we had antiretroviral therapy, this was a death sentence. It is no longer a death sentence, and this is why I prefer not to use this term. So when the CD4 count starts to drop, when it becomes 200 or less, individuals become at risk for what are called opportunistic infections. These are infections that take the opportunity to kick you when you're down. And as the CD4 count gets progressively lower, individuals are at risk for an increased number of infections. And these infections are things that don't affect individuals with a normal immune function. some of these AIDS-defining conditions are here in this cartoon. We do see some cancers, Kaposi sarcoma, primary CNS lymphoma, but mostly we do see infections. And you'll see that MTB, pulmonary extrapulmonary, is also an opportunistic infection and an example of an AIDS-defining condition. So let's talk about where we are with TB HIV co-infection worldwide. In 2017, we had almost 1 million people living with HIV became sick with TB, and of those, 300,000 people died from TB associated with their HIV. As I showed you in where the greatest prevalence of HIV is, understandably, based on that, Africa accounted for 84% of these deaths. And people living with HIV are 20 times more likely to become sick with TB than those without HIV. And again, when we look at globally, the HIV prevalence in new and relapsed TB cases, you will see that the majority of this occurs in sub-Saharan Africa. This is where TB and HIV are co-epidemics. It's a syndemic, meaning that the two diseases basically spur each other on, and one is not going to improve the other without the other also being treated. They need to be treated together. So another visual of how TB and HIV interact together is our own reported TB cases in the United States. When we started out back in 1982, we had about 25,000 cases, and we were really pleased because through public health efforts, we were seeing a drop in tuberculosis. And then we saw a spike, and this spike corresponds to the peak of the HIV epidemic. And at this time, we saw TB outbreaks. We saw outbreaks of multi-drug resistant TB, and the relationship between TB and HIV became very apparent. And it became clear that folks with HIV were at higher risk for tuberculosis, and we had to do a better job at protecting those individuals and working on our public health efforts with regards to TB in the face of this new disease. And as we can see, we're down to 2016, 2017. Oops, sorry, I skipped that one. And here we are in 2018 with TB HIV in the United States. We have the lowest case rate of TB ever. We had a little over 9,000 new TB cases. And the HIV status was known for 85.3% of these TB cases. We would like it to be 100, but not everybody agrees to have an HIV test done. And importantly, while our TB case rates without HIV have declined significantly, our TB case rates with HIV have declined even faster. And this is because of widespread access to antiretroviral therapy. We know that 5.3% of TB patients with known HIV status were co-infected with HIV, and that's not a ton, okay? However, it still is a risk factor for people living with HIV, and it's something that we need to continue to be well aware of and protect against. So I've already showed you that HIV and TB can work together to produce very serious outcomes. And we know that when someone has a skin test that's positive, they're HIV negative, their lifetime risk of developing active TB is about 10%. If someone has a positive skin test and they're HIV positive, that yearly risk is 10%. So again, a huge risk factor. So how does HIV affect TB? After someone seroconverts, becomes HIV positive, their risk of TB increases. And this is largely due to the decline in the number of CD4 cells. And here I've used the word T helper cells. Some folks who've had HIV for a longer time use the term T cells as opposed to CD4 cells. As that immunity declines, the risk of TB increases. We also know that HIV is a risk factor for accelerated progression following TB exposure, and this is why we prophylax individuals with HIV with INH who have been exposed to an active case. How does TB affect HIV? TB increases the risk of progression to AIDS or death. It's not entirely clear how this happens. It could be increased by HIV viremia or increased CD4 activation. Additional TB risk factors in HIV, very similar to the risk factors we see in patients who are not living with HIV. Socio-demographic include being Black, Asian, or Hispanic ethnicity, being born or a long-term resident in a country with high TB incidence. And this is where we're seeing the majority of new cases in the United States. And this is mirrored in HIV positive individuals as well. HIV acquisition through drug use, homelessness, and proximity to an active TB case or TB risk factors. And then from the clinical standpoint, a low CD4 count and a high viral load increase the risk of TB, and failure to start antiretroviral therapy or starting it late in the disease process also put one at higher risk for HIV. I share this because I think it's a really telling quote. Michel Sidibe, who was the head of UNAIDS for a really long time, this was a quote from him, and I think it speaks volumes. When a virus, which is HIV, and a bacteria, TB, can work so well together, why can't we? Good question. Okay, so how do we prevent TB and HIV? I've already talked about this a couple times, and I'll talk about it some more until I'm blue in the face. We're very, very lucky to have the antiretroviral therapy available to us that we have. Antiretroviral therapy results in a marked decrease in the incidence of tuberculosis when it started. But what happens though is, and I'll show you this in the graph on the right, the lower graph shows time and the relative risk of TB, and the upper graph shows CD4 count. This individual, their risk of TB is pretty low, but then they become HIV positive, and their risk of TB automatically increases with the drop of their CD4 count. Their disease, they're not treated, and their CD4 count declines with a progressive increase of their risk of tuberculosis. They're started on antiretroviral therapy, and once that starts and their CD4 count starts to go up, their relative risk of TB decreases. But even as their CD4 count reaches a normal level, their risk of TB does not fall below where it was prior to its decline from HIV or from when they were HIV negative. So even though someone may be on HIV medications, have a good CD4 count, have a good viral load, they are still at higher risk of HIV than someone who does not. TB prevention in HIV is very similar to TB prevention in other high-risk groups. We test for latent TB at the initiation of HIV care. We will use a skin test or an IGRA. Either test, it doesn't matter. Either test is better than no test. It's what you have available to you. If the initial test was negative and at the time the patient's CD4 count was less than 200, we will repeat that latent TB testing once their CD4 count rises to greater than 200 after they started antiretroviral therapy. This is because there can be anergy when they're immunosuppressed. We repeat this testing annually if there's ongoing high risk for TB exposure, such as being incarcerated, living in a congregate setting, if they're actively using drugs, they're homeless, or there's a lot of travel to TB endemic locations. Again, like I just said, a skin test has decreased sensitivity in persons with advanced immunosuppression. IGRAs, particularly the T-spot, may be more sensitive in these individuals, and the T-spot in particular, because it harvests the patient's own mononuclear cells, and which allows them enough cells to do the test. And IGRAs perform similarly to the skin test in identifying people with HIV who could benefit from latent TB infection. And a lot of times in HIV clinics, we do try to do screening with IGRAs because a lot of patients will not come back. And this, of course, improves testing rates and knowing if the patient has latent TB, and then we can go and find them to start them on therapy. Who do we treat? we treat a positive diagnostic test for latent TB and no prior history of treatment for active or latent TB. And again, because these folks are at such high risk for developing tuberculosis after exposure to TB, a negative diagnostic test for latent TB, but a close contact of a person with infectious pulmonary TB also qualifies for TB prophylaxis. Just as in any patient, we need to rule out active TB before latent TB therapy. Everyone gets a chest x-ray and, if necessary, a culture, a smear, and a NAT. Latent TB treatment in HIV is very effective. It's not quite as effective in some populations of folks without it, but it still decreases the risk of TB by 62% and the risk of death by 26%. And this effect is durable. Because of a lot of new HIV medications and potential drug interactions, for most of my patients, they need to be put on 9 months of isoniazid. For those who are not receiving antiretroviral therapy for some reason, the majority of patients should be once they're diagnosed, or those folks are receiving an efavirenz or raltegravir-based antiretroviral therapy without another drug called Taff. I know it's alphabet soup. I will talk about it more in a little bit. Those folks could be put on 4 months of rifampin or 3 months of isoniazid rifampin via DOT. Again, drug interactions do hinder some of the ways we can treat these patients. I would like to share with you, this is so exciting for TB prevention in HIV patients. This was a study that was published in the New England Journal of Medicine in March of this year that looked at a month of daily rifampin plus isoniazid in 3,000 patients living with HIV, and they were followed for a median of 3.3 years. Again, one group was randomized to receive daily rifampin and isoniazid for a month versus 9 months of isoniazid, which is standard therapy. The primary endpoint was the development of TB disease. And in both groups, 2% of the patients developed TB disease. The groups had a similar percentage of adverse events. And what is one of the big problems in TB prevention is completion of latent TB therapy. The percentage of treatment completion was significantly higher in the 1 month group than in the 9 month group. It was 97% versus 90%. And what's funny to me, though, is that the 9 month group percentage completion is still remarkably high. So we'd like to know what they're doing. But this is great news. Again, though, the patients were on antiretroviral therapy that was either efavirenz-based or nevirapine-based. These are not HIV drugs that we tend to use a lot in patients. We have newer drugs with less side effects, and I'll go into those in a little bit. I'd like to now talk about a case, and hopefully this case will help illustrate some of the points that I'd like to make throughout the rest of my talk. Mrs. S is a 42-year-old Indian woman who presents with a recurrent breast abscess. She's lived in the US for 5 years. She's not traveled back to India. She is married. She has a 17-year-old son. And the abscess is surgically drained 3 times and it keeps on coming back. And, you know, this lady, unfortunately, she is uninsured. And going back and forth to the doctor has been quite a big strain on her and her family. The sample's finally sent for AFB and the culture is positive for tuberculosis. She is referred to the local health department to initiate her TB treatment. So this is a question for the group. Which of the following is not part of her TB workup? A symptom screen for pulmonary TB, a chest x-ray, examination of her neck axilla for lymphadenopathy, an HIV test, or none of the above. There's a whole lot of negatives in this.
So Beth, it looks like we've got about a third of people having voted, so we'll just give it a little bit more time before we use the poll. You're doing fantastic so far. I've really enjoyed your presentation. And one quick question I'd like to ask is that regimen you mentioned of 1 month of INH and 1 month of rifampin, is that something that's available now for providers to prescribe, or are we still kind of waiting for more operational type guidelines? And
At this moment, I don't think anyone has put this into place, and it's largely because I think I haven't used it. I haven't had a patient where I needed to use it. I think at this point, the majority of us are waiting for more operational guidelines, especially from the CDC, in order to use this in the United States.
Yeah, that's kind of what I thought too. And if there's still questions, I think about Rifampin drug interactions.
Yes.
About 2/3 of our group has voted, so I think we could probably go ahead and close the polls, Linda. And it looks like about 6% of people felt that you don't need to do symptom screenings. And I think it's possible that being sort of a double negative question, those people, 1% did not think that a chest x-ray is needed. About 21% weren't sure that you needed to examine for lymphadenopathy. 11% said no HIV test, but the majority of respondents chose the last option, none of the above. Do you want to talk about that?
Great. Okay. So the answer is none of the above, and it is tough because it is a double negative question. I was testing your test taking skills, and it was just sort of one way to get all those things in there. Those are all things that you're going to do for anyone who is referred for you for TB treatment. One thing I'd like to focus on first, though, is HIV testing. HIV testing is one of these things that's changed over time because the diagnosis of HIV it carries is such a heavy diagnosis, and there's stigma and shame that's associated with this. For a long time, we did pre-test counseling. The patient had to sign a form that said they agreed to the test. Once they get the test result, they had post-test counseling, and all of that counseling and signing forms basically made it really difficult to test people for HIV. So in 2006, the CDC issued guidelines that advocated routine voluntary HIV screening of all patients ages 13 to 64 years in healthcare settings. And it's termed as opt-out testing. In 2013, the United States Preventive Services Task Force also recommended this, and they were a little late to the game with that recommendation. And the age range is 15 to 65 years. So what is opt-out testing? Opt-out testing is saying to the patient, I test everybody for HIV as part of routine healthcare. I'm going to give you a test, okay? Or I'm going to test you today, okay? And so you present it to the patient as that this is what we're going to do. This is why we're going to do it. We do it for everybody. Everyone should know their status. And then they have the ability to decline, and they say yes or no. This is very important because no one has to sign a form. You do have to document that you asked the patient and then they gave at least verbal consent to get the test done, because there's nothing worse than testing someone, not asking them, and having it come back positive, and then you have to go tell them when you didn't ask them if you could do it in the first place. The CDC recommends HIV screening for all TB patients. And I hope the reason for this is obvious. We know that HIV infection is the most important risk factor, known risk factor for progression from latent TB to TB disease. We should be doing it in persons with active TB, persons with latent TB, people who we suspect of having TB, and then the contacts to TB disease. When we identify these folks with HIV, it allows for us to get them into care, to get them started on antiretroviral therapy, to help prevent their TB risk by starting antiretroviral therapy, and also increase their life expectancy and quality of life by helping to control their HIV. The test that we use is called the 4th generation test, and it's a 2-step test. The first part combines an antigen antibody, and if that's positive, the second part of the test just looks specifically for the antibody. And if that's positive, and it's fortunately we can test for HIV-1 and HIV-2. HIV-2 is seen in West Africa mostly. What we have in the United States is HIV-1. And if both tests are positive, that person has HIV. Sometimes this test, the second test, will be negative, and at that point the test will reflex to do a viral load. Sometimes the second part of the test can be negative because the person's so early on in their HIV infection they haven't developed the antibody yet, and that's what we call acute HIV infection. As you can see, this new 4th generation test allows us to diagnose someone much earlier in their disease process, as early as 15 days after they've been infected. This allows us to get that person into care on antiretroviral medications. And once we control their HIV, actually they're at less risk of passing it to their partners or their partners. This is called treatment as prevention. So Mrs. S, so her symptom screen, was negative, no fevers, no chills, no sweats, her chest x-ray is normal. She has no evidence of cervical or axillary lymphadenopathy on exam. And she started on 4-drug TB therapy with RIPE. And there was a little bit of delay in getting this result, but her HIV test is positive. And her husband also tests positive of someone who is as her sexual partner. And so one of the reasons that I'm brought this case up is because Mrs. S is not necessarily someone you might think of who would be HIV positive. And her presentation of her TB is actually very typical of what we're seeing in folks who have HIV-associated tuberculosis. A lot of these folks are non-US born, and a lot of times there's extrapulmonary TB. Now that you know that she's HIV positive, would you go back and redo the symptom screen or relook at her chest x-ray? And I might. Would I go back and see if she has more TB, really do a good cervical, like a good neck exam looking for lymph nodes? And I probably would. And the reason is because when we diagnose active TB and HIV, how someone presents is really influenced by how far along their HIV disease is, the degree of immunodeficiency. For instance, in someone who's HIV positive and their CD4 count's greater than 200, their TB usually clinically resembles disease seen in HIV negative people, a pulmonary disease with a typical x-ray. The lower your CD4 counts get, the more of an atypical presentation of a disease it can be. And this is where we also see a lot of extrapulmonary TB, again, with or without pulmonary involvement. And it's particularly seen with advanced immunosuppression, and we get lymphadenitis and you can get meningitis. So you really have to have a high level of suspicion in these patients. The diagnosis of pulmonary TB and HIV, the patient can have an atypical chest x-ray, in someone with early HIV where they're not immunosuppressed. Again, they can have cavities, upper lobe lesions. When they're severely immunocompromised, we may see lesions in the lower lobes and middle lobes, and a lot of times we may see miliary disease. Cavitation is also less common, and this is because individuals don't have an immune system to actually respond and fight the bacteria to cause a cavity. In addition, lymphadenopathy, particularly mediastinal, is more common. Most folks infected with HIV positive people infected with pulmonary TB do have symptoms. They may have a fever, cough, weight loss, or night sweats. This is sensitive for the diagnosis of TB, but it's not very specific because as folks have progressive immunosuppression with HIV, they're at risk for having more opportunistic infections, which can have a similar presentation. And sometimes you don't just have one infection at a time. Individuals with HIV and pulmonary TB are also more likely to have AFB smear negative pulmonary disease than folks without HIV. And like we talked about, the skin test and the IGRA having being less sensitive in HIV positive individuals, 25% of those with HIV and pulmonary TB may have a negative skin test or an IGRA. In these folks, you do want to obtain 3 sputum smears and culture with NAT on at least one of the smear, and for the most part, we use the Gene Expert. Interestingly, this is less sensitive amongst folks with HIV than those who don't have HIV with a sensitivity of 80% versus about 89%. And this is probably because the expert is less sensitive in smear negative TB, and a lot of patients with pulmonary TB and HIV are smear negative. There are some studies that show, though, that it may be more sensitive when people have lower CD4 counts, and so that's something to think about. It's certainly worth doing. One of the really very cool tests that's out there that we don't have access to in the United States is the lipoarabinomannan, otherwise known as the LAMP test. That is a point of care test for TB. And what the LAMP is, it's a TB cell wall polysaccharide that can be detected in the urine of TB patients. And as you can see, it sort of looks like a little pregnancy test indicator. And what you do is you can be with the patient in the field, particularly in some place where there may be a high TB HIV co-infection. You get them to pee in a cup, you incubate it, you add 2 drops of the stuff that you need. And in 60 minutes from the time you collect the sample to when the result is done, you could have a diagnosis of tuberculosis in someone who has HIV. Interestingly, the best performances in HIV folks with a CD4 count less than 100. The sensitivity is really quite low, but the specificity is high, and there's a higher sensitivity in patients who, interestingly, have worse prognoses, who are sicker. If this is combined with gene expert on a smear, or gene expert or a smear itself, it can improve diagnostic utility, and this can be used in patients with pulmonary and extrapulmonary tuberculosis. We do not have access to it in the United States at this time. So back to Mrs. S. She's seen in the HIV clinic the next day, and this is something that's called linkage to care. Getting someone hooked up with HIV care is half of the battle with regards to getting them on medications and helping control their disease and preventing transmission of HIV. And a lot of times, so in the state of Florida, we do something called test and treat, where an individual who is diagnosed with HIV can be started on antiretroviral therapy at the health department that same day. And it's been pretty successful. So she's seen the HIV clinic the next day, so good job. And this is all at the health department. She has labs done where a CD4 count is 300. So it's not as low, she doesn't have a diagnosis of AIDS per her CD4 count. Okay, she basically does, though, based on her diagnosis of extrapulmonary TB. So she's, her CD4 count isn't too low, and her viral load is not that high either. It's 25,000. She's been on daily RIPE at this point via directly observed therapy for 5 days, and it's important. Folks with HIV should be on daily therapy. They tend to have better morbidity, mortality outcomes, and thrice weekly regimens in HIV positive patients led to rifampin resistance. So we do like to treat people daily with daily DOT. We're now to a polling question. When can antiretroviral therapy be started? Now, within 2 weeks of starting TB therapy, within 8 weeks of starting TB therapy, after TB therapy has been completed, because there are too many drug interactions if you try to treat both TB and HIV.
So Beth, so far we've got about 43% people voted. I'll just give it another minute. And I just wanted to remind the audience, we're going to cover questions at the end of this webinar. So please be thinking of things that you'd like to ask Dr. Gadkowski, and she will answer those questions at the end of the webinar. And so I think, Linda, we could go ahead and close the poll. We've got about 2/3 of our participants who have voted. And you guys can see that about 57% of people want to go ahead and start antiretroviral therapy right now. Another quarter of the participants want to start, wait 2 weeks and then start TB therapy. And then about 18% want to go ahead and wait within 8 weeks to start TB therapy. So Beth, why don't you let us know what you think the best answer here is?
Okay, excellent. Good job. As Dave Ashkin says, you've all exercised your right to vote, which is very important. So thanks for doing that. Whoops. I guess, sorry, I thought it lit up. It doesn't. So actually the timing of antiretroviral therapy and TB HIV disease really depends on the patient's CD4 count. When they are very immunosuppressed and their CD4 count is less than 50, you want to start antiretroviral therapy within 2 weeks of starting TB therapy. When their CD4 count is greater than 50, you usually wait a little bit longer. You wait until that individual is through the initial phase of their TB therapy with the 4 drugs, because it can be pretty challenging for that patient. And data has shown that it's okay in these patients to wait a little bit longer. And when TB occurs in patients who are already on antiretroviral therapy, you start TB meds immediately and then choose either Rifampin or Refuting based on what antiretroviral therapy they're on, so you don't have any drug interactions. Really important is that in TB meningitis, we don't start antiretroviral therapy early, regardless of CD4 count. Those patients have not benefited from early antiretroviral therapy, and these patients tend to be very, very sick. And if you have a patient like this, I would recommend speaking with TB and HIV experts in deciding when to start antiretroviral therapy. So concurrent therapy in ART and TB HIV disease, concurrent therapy in TB HIV is very difficult because there can be a high pill burden. There's the increased potential of drug toxicity, and there's definitely the increased risk of drug interactions. There's also the risk of TB-associated IRIS, which is the immune reconstitution inflammatory syndrome, which can happen especially in individuals who start antiretroviral therapies soon after being started on TB meds and have a very low CD4 count. But we know that if you delay antiretroviral therapy until after TB meds are completed, there's an increase in AIDS-associated morbidity and mortality. So what we do is we start it as basically based on CD4 count. So in this patient, she was started on antiretroviral medications after she completed her initial phase for TB therapy after about 8 weeks. Important to know is that co-treatment of HIV-related TB improves survival, particularly for people with low CD4 counts. Once you get someone on antiretroviral therapy and their viral load goes down and their CD4 count goes up, you decrease the risk of additional opportunistic illnesses. People can achieve high rates of viral suppression when they're taking their TB meds and HIV meds. We know that it can improve TB outcomes. And even though there's a higher risk of IRIS, it's not necessarily associated with other rates of treatment-related adverse events. We'll talk about that a little bit more. Okay, on to a polling question. So Mrs. S has been doing pretty well on her TB meds. She's feeling a lot better, and she's coming to the clinic to start her HIV meds. And she's seen this flyer in the waiting room for a drug called Biktarvy. It's a single tablet regimen, and the acronym for that is STR, to treat HIV. She would like to be on just 1 pill a day since she's already on so many TB medications. Is Biktarvy an appropriate option for her, yes or no?
So Beth, about half of our participants have voted, and I'm just going to give it another minute. You guys get your responses in for us. Exercise that right to vote. Again, the question is Biktarvy an appropriate option for this patient at this time? Beth, how have you ever gotten good at pronouncing these HIV medication names?
Oh my gosh, it's pretty hard. I'm working right now with a pharmacy resident who's coming to our HIV clinics, and we spend all day doing tongue twisters, basically, with the pronunciation.
Then you throw in a few biologics and some.
Yeah. Yeah, we have no idea what we're saying by the end of the day.
Okay, well, I think Linda is probably okay to go ahead and close the voting. And Beth, it looks like you're about 50-50 here. About 40% say
okay.
yes, and about 52% are saying no.
Fantastic. That's great. Okay, so the answer is actually no, it is not. And this is kind of unfortunate. If she wasn't being treated for tuberculosis, yes, it would be the first line. And unfortunately, she's on TB medication, so it's not appropriate for her. Let's take a look back at the medications that we, the history of HIV medications. In 1987, we had zidovudine or AZT that was our first HIV medication. And since then, numerous other drugs and different classes have been developed. And part of the problem with the early antiretroviral medications is that they had very bad side effects. A lot of patients couldn't tolerate them. There were numerous pills that needed to be taken numerous times a day. And a lot of people, especially with early antiretroviral therapies, couldn't take the medications. The medications were making them sick, and they stopped the medications and they subsequently died, unfortunately. We got very lucky in 1996 when the protease inhibitors were developed and started to be used, because we knew at that point, by combining different medications that affected different parts of the HIV life cycle, that we could control the virus. And since then, we've been working on developing more tolerable regimens that are taken less frequently, less side effects, and so people can actually have a really good quality of life. And here we are in 2018, and we have a tremendous number of options for patients that are very well tolerated. So we have greater than 30 antiretroviral drugs in 7 different mechanistic classes. And again, what we do is we combine 3 or more drugs usually that affect different parts of the HIV life cycle. The way that I like to explain it to my patients is that it's like going to war. When you go to war, you not only, you don't just have the Army come in, you also bring the Air Force, you also bring the Marines, you also bring the Navy. And that's what we do when we treat HIV. We attack it from different aspects of the life cycle. The drugs that we are using most commonly now, and what are recommended as initial regimens for most people living with HIV, meaning that these are folks who have not been on HIV meds before, they're starting meds for the first time, are integrase strand transfer inhibitors, INSTIs, and we call these integrase inhibitors. And what they do is they block the integration of the HIV DNA into the CD4 cell DNA. And the recommendation is that we use regimens that have demonstrated durable virology efficacy, favorable tolerability and toxicity profile, and ease of use, meaning that people can take them easily and not get sick, and that they do their job. So the HIV treatment guidelines, the recommended initial regimens are these integrase inhibitors. And there are 3 that are available at this time: dolutegravir, raltegravir, and bictegravir. Elvitegravir is also on here as well. It is a boosted regimen and is not considered to be first line. And just like with any HIV drug, there is the trade name, the generic name, and then also a 3-letter acronym. The integrase inhibitor is recommended to be combined with a backbone, and 2 nucleoside or nucleotide reverse transcriptase inhibitors make up the backbone. So most patients are on 3 drugs at one time. We now have a new form of tenofovir, which is called Taff, and this drug was developed to help prevent the renal dysfunction and bone issues that we're seeing with the prior form of tenofovir, which is known as TDF. For those of you who know about HIV, you're probably saying, where's my protease inhibitor? Where's my ATRIPLA? Well, they're still in there. There's still regimens that can be used. It's just that they're not necessarily recommended first line anymore. As you can see at the top, it says these regimens are effective and tolerable, but have some disadvantages when compared with the regimens listed above, or have less supporting data from randomized clinical trials. However, in certain clinical situations, one of these regimens may be preferred, okay? So let's look at our integrase inhibitor single tablet regimens. And I put these pictures up here so you can kind of get a feel for how big they are. The drug of choice right now that most individuals are being started on that are newly diagnosed with HIV is Biktarvy. And Biktarvy is a single tablet regimen that combines bictegravir, emtricitabine, and tenofovir alafenamide, which is the newer form of tenofovir, which is Taff. It's not necessarily a one-size-fits-all tablet, but it is incredibly well tolerated and is incredibly effective as well. Others, single tablet regimens that include integrase inhibitors or Triumeq, which includes dolutegravir, and then Genvoya. Just to talk a little bit more about Taff. Taff is the newer form of the tenofovir, and again, it's used as part of the backbone of most recommended antiretroviral therapy. And if you take a look at all these pictures, it comes by itself, but then it comes co-formulated as Descovy with emtricitabine and is part of numerous single tablet regimens. Really important big star next to the current DHHS guidelines do not recommend co-administering Taff with rifampin, rifabutin, or rifapentine. So if a patient's on any of these co-formulated regimens, it can't be used. And this is a resource that I'd like to plug. It's from the North Florida AETC, and it's available at the link below on the website. And basically, we want to use rifampin in patients with HIV if we can. But if they're on a Taff-containing regimen, such as Biktarvy, Descovy, Genvoya, or Defcy, we can't use rifampin. What about our integrase strand transfer inhibitors? So our friend Biktarvy, which is our single tablet, bictegravir does not come by itself, but again, we can't use rifampin with that single tablet regimen. And dolutegravir, which is an integrase inhibitor, which is well tolerated, that does come separately, we would have to increase it to twice a day. Okay, raltegravir, which is already a twice-a-day integrase inhibitor, would have to be increased to 800 milligrams twice a day. And so with our newest regimens that the majority of individuals with newly diagnosed HIV are being put on, we can't use our standard TB medications without making a change in that individual's regimen. So unfortunately, Biktarvy is not an option for Mrs. S. What if we use rifabutin? So rifabutin, unfortunately, like I stated before, can't be used with Taff-containing regimens. There is some data that suggests that there's some PK data that suggests that perhaps this may change in the future as we get more information. There are no dosage adjustments for dolutegravir with rifabutin and also with raltegravir, but again, we can't use Biktarvy or elvitegravir, which comes in Stribild or Genvoya. One thing I want to point out is that if you say, for instance, you have a patient who is HIV positive and comes in and is already on a protease inhibitor, you could use a protease inhibitor in rifabutin. I would not recommend using a protease inhibitor in rifampin, but the dose of rifabutin needs to change. And if folks are not taking their antiretroviral regimens regularly, then the rifabutin dose would be subtherapeutic. So this brings us to the concept of adherence. And so patients need to be adherent to their TB and their HIV medications throughout the course of their treatment. So because Mrs. S desires a single tablet regimen to treat her HIV, we go to our old standby, which is Atripla. And some of you may recognize this. This A triplet is a combination of efavirenz, emtricitabine, and the older form of tenofovir disoproxil fumarate. This was the first complete single tablet regimen for HIV treatment that was available in 2006. And it used to be a first-line agent for treating HIV, and it fell off the preferred list because patients were experiencing severe depression, and there was an increased risk of suicide with some of these patients. And so we still use it. It's actually considered to be the gold standard of HIV treatment in someone who has tuberculosis. But again, it may be something that we start that individual on while they're getting their TB treatment, but then switch them to something else once their TB treatment is over. Some of the side effects include rash, renal insufficiency, some hepatotoxicity, and then the CNS side effects are well known. It can cause vivid dreams and hallucinations. Those usually go away by about 2 to 4 weeks after starting the medication. Again, medication adherence is really important. Some of the typical barriers to adherence in HIV TB are very similar to what you see in just TB patients. There's a complicated treatment regimen. There's a lot of side effects to these medications. Sometimes it can be very difficult to access medications. Active substance abuse, depression, and lack of family and social support can hinder adherence to these medications. So how do you improve this? You simplify all the regimens you can, if possible. And that's why putting Mrs. S on a triplet single tablet regimen is a good idea. We choose the shortest treatment regimen for TB as possible, do our best to find resources to assist with the treatment costs and helping patients get to clinic and do whatever we can with regards to that, using incentives and enablers, assisting with transportation, linking folks to counseling for help with substance abuse and depression, and also having a case manager and a peer. And a peer can be someone with TB, the person can be someone with HIV, the peer can be somebody who has both. Briefly, I'd like to talk about adverse drug reactions. And we often think that when you're treating somebody for HIV and TB at the same time, that there's going to be a lot more drug reactions. And actually, that's not the case. A randomized control study showed that there were similar rates of adverse events during anti-TB therapy with or without antiretroviral therapy. So there's really no significant added toxicity when antiretroviral therapy is given with TB therapy. The big problem can be distinguishing which drug caused the reaction when you're using so many drugs. Some of the shared reactions include skin rashes or drug-induced liver injury. And the fancy name for skin rashes are cutaneous adverse drug reactions. And these can occur with any of the first-line TB drugs like rifampin and isoniazid. And a lot of the antiretroviral drugs like efavirenz can cause a rash, which is part of a triplet. If it's a minor rash and it's affecting a small area with some itching, antihistamines, and continue antiretroviral therapy and TB medications. If the person has a generalized rash and it's associated with fever or drug-induced liver injury, or if there's mucous membrane involvement or desquamation, which means that their skin is peeling off, you stop all the TB meds, and I'd stop all antiretrovirals as well. This is a really tough situation, and the way that I word it next, when the rash is substantially improved, sequentially restart TB drugs. You do want to start TB meds first. This is really tough. When these people have a drug rash, they can be incredibly sick, and it can be incredibly frightening to restart medication. So if you're going to do that, I would recommend the patient be monitored incredibly closely. And if the rash occurs, obviously the last drug that's added should be stopped, and you modify your TB regimen. Then you go back to starting antiretroviral therapy. And we fortunately have enough drugs that we usually can come up with a regimen that the patient will be able to tolerate. Drug-induced liver injury is the way it's managed in HIV TB is the same as the way it is managed in just TB alone. Isoniazid, rifampin, pyrazinamide, and many of the antiretroviral drugs can cause drug-induced liver injury. The antiretroviral drugs where we see this the most again are the non-nucleoside reverse transcriptase inhibitors. And this is when the ALT is greater than 3 times the upper limit of normal. They have symptoms fever, rash, fatigue, nausea, anorexia, and jaundice, or it's greater than 5 times the upper limit of normal without symptoms. You obviously stop all the potentially hepatotoxic drugs, you evaluate the patient, and send serologic testing for hepatitis A, B, and C. And hopefully, if they're HIV positive, they've already had all those done. And then you question them about exposure to other hepatotoxins like alcohol and Tylenol. Rechallenge is the same as in non-HIV. You start the first-line anti-TB meds one at a time at intervals of 5 to 7 days after the AOT level returns to less than 2.5, the upper limit of normal. And we always want to start the rifamycins first. In hepatotoxic situations, rifabutin tends to be a little less hepatic toxic, so that can be substituted for rifampin. And we always use ethambutol at the same time. After the TB meds are back on board, that's when you restart your antiretrovirals. And again, a lot of times we can modify the regimen for the HIV regimen. It may not be the most convenient, however, it may require several meds that are more than once a day dosing. Briefly, I'd like to touch on TB IRIS, which is the TB-associated immune reconstitution inflammatory syndrome. And IRIS is a big concern in HIV itself and also in TB HIV. And this is what is akin to the paradoxical reaction that you see in patients who just have tuberculosis, when they're getting better on TB medications and all of a sudden they get worse. And this happens not infrequently in TB HIV. It's thought that the immune system is recovering by treating both the TB and the HIV, and but the body is now able to target an inflammatory reaction towards the MTB that's in the body. And usually the person has lymphadenitis, worsening infiltrates on chest x-ray, or fever. And there are two forms, the paradoxical form and the unmasking form. The paradoxical form is which occurs after the patient's been started on antiretroviral therapy, when they're already on TB treatment. This happens pretty frequently, actually, in most series. It's reported in 48 to 54% of individuals. Some of the risk factors for this is when someone starts antiretroviral therapy at a very low CD4 count, especially when it's less than 100, a high viral load also. So for instance, if someone starts out at a viral load of 1 million or 500,000, dropping that viral load quickly can lead to IRIS. If they have extrapulmonary disseminated TB, and if there's a short interval between starting TB treatment and ART. It usually occurs, the symptoms occur about 1 to 4 weeks after ART's initiated. And typically, of course, patients have improved on their TB treatment prior to starting antiretroviral therapy. So it's after the first few weeks of ART that they'll develop new, worsening, or recurrent clinical and radiological features of TB, fevers, lymphadenopathy, pulmonary infiltrates. And the problem is it's a diagnosis of exclusion. There's no definitive test. You have to see that they're having a characteristic clinical presentation where they had already improved their TB prior to ART. As a couple of weeks after starting ART, they deteriorated with fever and worsening infiltrates. And also this is when you want to check a CD4 count and the viral load, because this will help confirm your suspicion that this is IRIS. The CD4 count will rise, but more frequently, the viral load will have dropped incredibly quickly. You also, though, have to make sure that there aren't any alternative causes for deterioration, especially undetected TB drug resistance. And this tends to last around 2 to 3 months on average, and it's self-limiting. Symptoms can be handled with NSAIDs or antiemetics. And if people are really quite sick, prednisone may be used. And sometimes prednisone needs to be used for a long time and because of prolonged symptoms. And we do our best to try to taper them. But sometimes as tapering occurs, the symptoms recur. So tapering needs to be guided by symptoms. And sometimes folks can develop cold abscesses or suppurative lymphadenitis. And these oftentimes need to be drained to help them feel better. Unmasking TB IRIS occurs in patients who have unrecognized TB at the start of antiretroviral therapy. And sometimes people do have TB or we just didn't do a good job asking them about their symptoms or paying attention to their symptoms. And usually what happens is that after they're started on antiretroviral therapy, they get really, really sick, and they get a fever, and they have respiratory symptoms, and it really looks like a bacterial pneumonia. And a lot of times we don't necessarily think of TB, but it is. They can also have abscesses and lymphadenitis, and the standard treatment is TB treatment. At this point, you would continue that patient on antiretroviral therapy as well. You can use steroids if the symptoms are life-threatening, but hopefully TB therapy, the institution of TB therapy will help with the unmasked TB virus. So one last polling question for the group, and thanks for hanging in there with me. It's easy to tell that someone has HIV just by looking at them. True or false?
That's a great question to end on, Beth. We've got about 65% of patients voting. So Linda, why don't we go ahead and close the poll?
Oh, that was quick.
Looks like the group is unanimous that the answer is no.
Okay, good. Just testing. All right. So this is, it's sort of funny. I work with medical students and residents, and this is a question I often ask them. And this is a question that I see with my patients too, when they're newly diagnosed and they say, but I don't feel sick and I don't look like I had HIV. And so what the general thought of someone who has HIV is that they are not well, they're very skinny, they are that they are just sick. And that's not the case. That may have been the case a long time ago, and that's what we would see in the media, but it is no longer the case. And what's really important is that there's a tremendous amount of stigma associated with HIV, just like tuberculosis. And when we're caring for somebody who has TB and HIV, it's really important to treat them just as we would anyone else. And to help them be successful. And the shame and the stigma that is associated with the diagnosis of HIV often leads people to not seek care. In HIV, we use something that's called the cascade of care, or the continuum of care, where what our goal is to get people diagnosed, linked to care, on medication, retained in care, and that their viral load is suppressed. And once their viral load is suppressed, and they're doing well and the virus is controlled, they can actually live a normal, healthy life. And the average lifespan of folks with HIV is actually 71. So medications, HIV medications are remarkable. And there's something called U equals U, which means undetectable equals untransmittable. And individuals with a viral load that is undetectable are at have virtually zero risk of sexually transmitting the virus to their partner. So this is an incredible time for individuals living with HIV. However, there's still this tremendous amount of stigma that is associated with the diagnosis that often prevents individuals from engaging in care. And if we can, in the TB community, provide HIV competent care, and test our patients with HIV and let them know that it's something that can be treated, that they can live a normal life, I think that's just a wonderful thing to be able to do for a lot of these individuals. So I'd like to share with you some of the resources, the treatment of TB in adults with HIV infection pocket card, which is available at the AETC website. And the majority of the information that I presented to you today is in the guidelines for the prevention and treatment of opportunistic infections in adults and adolescents with HIV, which are found at the AIDSinfo.nih.gov guidelines. And they're really readable, they're really usable. The TB section is in the process of being updated. And so it's just another good resource to have. Thank you so much for your time.
Hey, Beth, that was wonderful.
Yes.
And you channeled Dave Ashkin earlier, so I'm going to do the same now. outstanding, just
Oh,
outstanding.
thanks. Oh my gosh, thanks guys.
And to further channel him, especially for an infectious disease doctor.
Oh yeah, I know.
Of which both of
Thanks.
us are.
Yeah.
He likes to pull his pulmonary card. So listen, we've got plenty of time for questions and answers, and I would encourage the participants to go ahead and type in the question box things that you'd like to know. And in the meantime, Beth, I'd like to go ahead and ask you a few questions that people have already posed so far.
And you know something, Connie, I may not know, if I don't know the answer, I will certainly look it up and get back to folks.
Oh yeah, of course, yes. I will tell you that I'm getting a lot of feedback that people agree it is outstanding and fantastic and lovely presentation. So don't, you know, none of us know.
That's very kind, thank you. I wish I could be with you in person, however.
I know. So the first one I think you'll really be able to address quite well. And the question is Rifampin or Rifampin the better drug to use, or in what circumstances do you use one versus the other?
Oh, Rifampin or Rifampin?
I'm sorry, Rifampin or, well, they did say Rifampin, but maybe you could just talk a little bit about.
Isn't this one used in people living with HIV when they've been exposed to someone with active TB? Is that the question?
Yeah, I think I'm sorry, I wrote it down wrong in my little cheat sheet.
Oh, so when we're dealing with someone who is a contact to a case and they have HIV, we will usually use isoniazid. And that is largely because we're going to get that person on HIV medications right away, and we can't use Rifampin or Rifampin with majority of the HIV meds we're going to use. And for a lot of people, so what's fascinating is that I actually have never used anything but isoniazid in prophylaxis of patients who have been contacts with HIV. And I'm not currently aware of the data with regards to using Rifampin in that setting, but I can certainly find out.
Yeah, and so that's specific to contacts. And I do want to highlight on that pocket card with TB HIV, which Beth and I have written together with Joanna Urban, there is, you know, a table that includes drug-drug interactions for LTBI as well as TB. And so that card can really be helpful when you have patients that you're treating preventively with an LTBI regimen. Beth, another question that came up earlier in your presentation was how frequently should a person be screened who is positive? And so I'm assuming they're saying, you know, maybe you could even answer it both ways. If they are known to have HIV, how often do you want to screen them for tuberculosis? And then the second question you could answer is, if you know they have a positive HIV and LTBI infection and you don't treat them, you know, should you be screening them for TB disease?
Yes. Oh, that's a great question. And so usually we test somebody when they're initially entered into HIV care for latent TB infection, and then we will test them again if that first test was negative and their CD4 count was less than 200 at the time when it was tested. We'll test them again when it's greater than 200 because of anergy. But we don't annually test our patients with HIV for TB unless there's some ongoing exposure. And I think probably one of, you know, the ongoing exposure would be, oh, they were incarcerated. And usually they would have had a skin test that was done as part of that incarceration. Or they are unstably housed, or they are from a country where there's a high prevalence of TB and they've gone back and spent a lot of time and then they've come back again. And so we don't do annual testing. What we do is we assess the risk for that individual being infected based on their lifestyle. And then what's really challenging is when you have someone who has a positive skin test and for some reason you can't treat them or don't treat them. And those folks I would usually when you see patients, we largely see our HIV patients, and if they're in care, we see them depending on their CD4 count and their viral load and how they're doing. usually twice a year if they're doing really, really well. And those are opportunities for me to do symptom screens with those individuals. And I don't necessarily usually do a chest x-ray on them. I don't have a lot of patients actually that haven't been treated for latent TB. We're pretty aggressive with doing it. But if someone were to refuse, I would symptom screen them pretty regularly, and I would work really hard on making sure that they are adherent to their HIV meds, because again, having a good CD4 count and an undetectable viral load is going to reduce their risk of reactivating their TB. I would work on them to try to get their 9 months of isoniazid into them. And these are the kind of patients where once the monthly rifampin and isoniazid becomes, hopefully becomes something that we use more regularly, perhaps those are the kinds of patients that I might, try to get on that regimen. But a lot of our patients are getting put on these newer single tablet regimens, and it becomes, and they like it. They like it. One of the best things I can do for someone is give them, is make HIV a chronic disease for them, where they take one pill once a day and it controls the infection. And the success of that sometimes outweighs the ease, and I'm speaking pretty frankly, that outweighs, how I'm going to make TB treatment, latent TB treatment, easy for them, for instance, right? So sometimes it's a trade-off.
Right. And you may have said this, but there is very strong data that starting antiretroviral therapy is actually a tremendous way to prevent active TB disease.
Yes.
You give them back their own immune system, that decreases their risk of progression from latent to active. And the data also says, INH works, using antiretroviral therapy works, and if you use them both together, it really, really works. So
right. And the slide, if you guys remember the slide where it has the red line and the blue line, and that basically shows in graph form how the starting antiretrovirals really decreases the risk of TB once that individual has been immune reconstituted, which means that their HIV is under control and their immune system is back working again.
Yeah. Well, great. Well, let me ask you, I've got some more questions here. One is, after you've stopped the TB meds and you're going to now switch them to one of the stronger, more strongly recommended HIV regimens that might be one pill, do you need to wait? Is the half-life of rifampin and its drug interaction effect?
Oh yeah.
Period?
Yes. So, oh my goodness, that's a great question. And yes, you would. And it actually depends on the drug that you would use. And so because of the half-lives of the different, it's different based on the different antiretroviral that you use. There's some data looking at the use of dolutegravir twice a day with Truvada dolutegravir twice a day in the treatment of TB, very successfully used, very well tolerated. But what happens is that you have to wait a while, and I can't tell you exactly how many days or weeks before you would go back to using dolutegravir once a day after you started Rifampin.
Mm-hmm. And I think, rifampin may stay in the system for a few weeks as well. So using rifabutin or rifampin, other drug interactions, may remain for a while. So if they're also included or something else, you really need to kind of continue to monitor those patients closely. And we can get therapeutic drug levels for HIV meds as well as for the TB meds. And Dr. Peliquin's lab does that. And I would imagine that's also something that's possible other places, that like National Jewish, perhaps. I'm not sure about that, but do be aware that Dr. Peliquin's lab is useful for, helping us manage patients on both TB and HIV therapy. Beth, another question about treatment logistics. Do you define DOT for patients with HIV as either 5 days or as 7 days?
Oh, I do the 7 days. Sorry, the 5 days. Sorry. I do it the same as everybody else. You gotta, you take what you can get.
Yeah.
And with the understanding that people will self-administer on the weekend, but we largely count it the usual way.
There is a question that says, how good is the data to combine rifabutin or rifapentine with either altegravir or dolutegravir? For example, do you double the INSTI dose with rifampin? And also, in light of this new England Journal case of acquired dolutegravir resistance when it's used with rifabutin? That's kind of a long question, but do you see that question, and can you respond to that?
So can I move back my slides to is that okay?
Yep, please do.
Yeah, so when you're using rifampin, you do double the dose of raltegravir, and you also double the dose of dolutegravir twice a day also. And the thing is, this can be really challenging for patients to do a twice a day regimen. You do increase the dosing, and this may be another opportunity to get drug levels. And what I would worry about is in that I'm not aware of the case with the dolutegravir resistance with the rifampin. I think that it is. Yeah, I would be concerned. I have to go back and I'll have to look at that case. But the question is, was the patient, how were they taking their medications? So when you have someone on a twice a day HIV regimen, you really have to be pretty great about taking them as close to the same time as possible, not taking with anything that's going to prevent their absorption. And so it becomes a little more challenging when you're using twice a day regimens. We have a lot of data on EAAA, and in many countries around the world, they may not necessarily have access to some of these other drugs. And so it's not wrong to use it, but it's just something that you're not necessarily going to have that person on for their life with their HIV. Did I answer all the parts of that question?
I think you did. You've got some more questions. I want to keep moving. Someone was kind of asking along the same lines of treatment. Patients who have TB and HIV and takes dolutegravir and Truvada. Did you talk about Truvada? And I think you did. I don't know if you want to reiterate.
You can use Truvada without a problem. Truvada it's the newer form of the tenofovir that is a problem that comes in Descovy, which is what everyone is substituting for Truvada.
Yeah, so no Taff, right? With
no Taff. That's correct.
So, another question that someone wanted to just remind us how important, we talked about screening all our TB patients for HIV, but also to screen all of our HIV patients with TB, and I completely agree with that question. I don't know how up you feel to go back a few more slides to your slide about where the different drug targets where, within the HIV replicated cycle, but someone wanted to know, the question is because it's a retrovirus, it's RNA, and the integrase inhibitor interferes with DNA. Can you just maybe talk through that a little bit?
I know, it's really confusing. So what happens is HIV comes and it attaches to the cell, and then it fuses with the cell. And the RNA is released into the cell, and there's something that's called reverse transcriptase that actually makes the RNA into DNA. And then that DNA can then be integrated into the DNA in the cell. And so it's this thing called reverse transcriptase that makes the RNA into DNA, which is one of the first targets actually for the drugs that we have to prevent this from occurring. So we use the nucleoside reverse transcriptase inhibitors, the tenofovirs, the Taffs, the emtricitabines, lamivudine, that block this step. So that's how that happens. It's very clever. The HIV virus is so clever, and this is the reason that we don't have a cure for it, and we have a hard time making a vaccine for it as well.
Yeah, that's great. That is really complex. You did a really good job of making that simple. So one more question I see here is, how would you treat latent TB in an HIV positive patient if the case they were exposed to had low-level INH resistance?
Oh my gosh, that's a great question.
Extend it to full INH resistance or even rifamycin resistance.
So these patients, you're going to have to. This is where I would call up Connie, actually. We would talk about it.
Friend of friend.
And this would be a situation where I might use Rifampin. And if it was a multi-drug resistant case, I would use something along the lines of just standard, MDR therapy. And it would really have to, and multi-drug resistant latent TB therapy. And this would be a sit down with the patient, see what they're on, really look at what kind of contact they are before I start running around and messing with their medications. I think a low-level INH, I probably would feel okay using isoniazid.
Maybe at the higher dose.
At the higher dose, yeah. And then
milligrams twice a week, perhaps.
Something along those lines. But the other ones, I would potentially treat that individual with other regimens. And to be honest with you, because we have so many issues with Rifampin in HIV, I don't even know the data that's out there for the use of Rifampin in HIV positive populations for contact prophylaxis, and I put it on my list to take a look at it.
Yeah, I agree. I really don't see that there's a lot of data on Rifampin. I do think that it's considered acceptable to substitute rifabutin, and you can again go to that resource we have from the AETC and the SNTC where you can look up drug-drug interactions. You can also call us at 1-800-4TB-INFO, and we can get in touch with, if we don't know the answer, we can get in touch with our pharmacy team and talk about what can we use in this patient. If you have to, we try not to mess with their HIV because we know that, we don't want HIV drug resistance to occur by switching them around. But sometimes if they're a high risk for developing drug-resistant TB, we'd want to make sure we nip that in the bud. It's easier to treat preventively with one thing than it is to throw in MDR treatment. And the last thing I want to comment on is I'm so thrilled that you mentioned sitting down patient to patient or, provider to patient, or even including their family. I think we've had so many recent advances both in diagnostics and soon in treatment. We have new drugs that we're using that can be substituted, certainly used for MDR TB, but can sometimes be substituted even with drug-susceptible TB for patients who have intolerance or resistance or just too many drug interactions or liver disease. And so it's kind of an exciting time to be doing tuberculosis care. And some of these options, especially when we're talking about drug resistance, require sitting face-to-face with the patient and giving them input. And that patient-centered care is really the way we should be managing all of our patients and not just those with HIV. So I totally agree with you. We are at the end of our time. I had one little tip that Dr. Ashkin likes to talk about. You mentioned energy, and of course we don't use energy testing when we do skin tests anymore. But something that's kind of cool about the interferon gamma release assays are that in the quantiferin test, you've got a mitogen, and also in the T-spot, you've got a mitogen test, which is it's a positive control. So if your patient with immunosuppression has a strong positive control, their mitogen level is high, that indicates they've probably got decent immunity, because remember, those tests measure the immune response and not the amount of TB in your body. So the positive mitogen says, hey, your immune system's working. And so sometimes we can kind of use that information. We're interpreting patients negative, we feel more comfortable that someone who's HIV and is negative is really negative if they can respond to the positive control in those IGRA tests. So I don't know if you use that trick.
Oh yes, I have. Thank you for reminding.
Yeah, I thought our audience might like to hear that. So Beth, you've been amazing. I'm just so thrilled with the information you shared with us. I feel like I learned a lot, and but based on the feedback I can see here in the chat, I think a lot of our participants did as well. People have hung on till the bitter end, and we're at the end of our hour and a half. I would guess you're willing to stay another few minutes if there's some last questions.
Absolutely, absolutely. Thank you so much, everyone, for joining me. And gosh, this is very passionate about HIV care, so I'm very happy to have you be here for this. So, and thanks for asking me, Connie.
Yeah. Beth, I just see one more question, and it looks like we can wrap up. Someone is asking why the TB LAM is not available in the U.S.
You know something, I don't know. I don't know why it's not available. I'm not sure if it's not been FDA approved. There are two different forms from two different companies, and it's not entirely clear to me. Connie, do you know is it because it's not FDA approved? Is that it? Or
I don't know the exact answer, but I think that part of the problem is that, and this is something we see often, tests are put more out into the rest of the world where, you know, there's more TB and more TB HIV, and the FDA is slower to use. I'm not sure the utility is going to be as great at the current level that the TB LAM picks up the proteins from HIV in the urine. I think it's most useful in patients with advanced HIV who have disseminated TB and therefore have more TB DNA to be picked up in the urine, because there's just such a higher burden of disease, and their immune systems don't work well enough to be killing it. So in the US, not as many patients present with advanced HIV like that, but I do think that it's worth talking about because it's the first of hopefully more to come diagnostics. It can be rapid and at the point of care, meaning done in the clinic, done at the bedside, where you can get answers back. And there's a similar story with Gene Expert, and with some of the multi-drug resistant TB drugs, they can get them very easily and very cheaply overseas. But here in the US, part of it's the companies wanting to make up their their profit. It's very expensive for us to get Gene Expert. It's very easy to get it overseas. And some of the drugs the FDA hasn't approved here, but they're approved and in use overseas. So I think there's a lot of advocacy trying to change that. Again, that's kind of my guess and not based on fact. So, but I don't see any more questions. I do see where is LAM used. I think it is used a lot in
South Africa. Yeah, in Sub-Saharan Africa, South Africa.
Yeah, world's highest rates in Southern Africa of TB and HIV. So a lot of testing and use there. But I want to thank you again, Beth. It's just been a fantastic webinar, and I'm sure that it will be as really popular once we posted the link on the web as it was having so many attendees live. So I wish all of you a wonderful week, and we hope to have you join us again in our next webinar.